Hello, and welcome to the MDU podcast, where we take an in-depth look at a particular topic that MDU members might face in the course of their career and explore its medico-legal issues and implications. In this edition, we'll be tackling the subject of migrainous headaches and looking at the features and pitfalls of their diagnosis and ongoing care. Joining us today in the studio are three members of the MDU's council. Until March 2017, Paul Riordan-Eva was a consultant ophthalmologist specialising in neuro-ophthalmology at King's College Hospital, London. Having retired from clinical practice, he continues as a medico-legal expert, which he began in 1993. He's been a member of the MDU Council and Cases Committee since 2003, as well as a member since 2006, and chair since September 2017 of the MDU Board of Management. Dr Alan Middleton was a GP in Foy until October 2013. Since then, he's continued to work as a locum GP, both in hours and out of hours, and continues to work as a GP medical expert. He's been a member of the MDU Council since 2005. Dr Paul Goldsmith is a consultant neurologist at Newcastle Hospital's NHS Foundation Trust and neuro-lead at the Northern Strategic Clinical Network. He qualified as a doctor from Oxford University in 1994 and joined the Specialist Register in 2007. He has particular interests in headache and movement disorders and has been a member of the MDU Council since 2016 and the main MDU board since 2017. So, over to our panel.
My name is Alan Middleton. I'm a general practitioner and have been so for some 35 years. And I was wanting to start by talking about migraine. Migraine is an incredibly common condition. General practitioners see many cases, and a lot of migraine sufferers are quite problematic because they are repeat attenders. There are several issues that a general practitioner has to be aware of, and the first thing is the diagnosis. Now, migraine is a chronic recurring illness with a lot of periods of normality. And my view on this is that a general practitioner should take an appropriate history and be absolutely clear when making this diagnosis that that's what they are probably dealing with. The point about migraine is there are no real tests, it's all based on the history. So what is a GP going to do? Most of the problems surrounding migraine are the symptoms that I consider can be problematic are the headache, the aura, which can be visual symptomatology, and there are neurological symptoms and signs. Now, each one of those three, if misdiagnosed, have quite significant consequences. Each one in their own can be harbingers of quite serious conditions. So it's very important to get on top of it and to take that good history. Now, I'm aware as a GP that I have many patients who have recurring migraine, and it's very incapacitating. They often miss a lot of time off work, and I can actually quote a partner of mine who was probably off at least one day a week, and we couldn't really stop it. There's not much he could do about it. So GPs are seeing patients. It's mainly GPs that deal with migraine. But the question then is, at what point do we have to consider that we want some other help? My own personal way of approaching this is that when somebody comes in with a recurring problem and they're coming in again, one of the important questions I ask is this your usual migraine, or is it different in any way? Because if it's different, you have to start thinking of other conditions. And the other thing is to consider what sort of examination you should be performing, and what should a responsible GP do, because there is jeopardy in not doing this correctly. And one of the talking points, and the one that always creates the problem, and hopefully Mr. Riordan-Eva is going to help me in this, is the question of looking at the fundi, which can be quite problematic. If I just very briefly mention that medico-legally I've done quite a lot of reports in relation to migraine and their problems, and I well remember a 13-year-old girl who had been treated for headaches and vomiting and visual aura for 3 or 4 years, was considered to be migraine, probably was, and then she appeared to have more frequent headaches. Sadly, in spite of all that, she wasn't fully examined. She went to the optician because she thought the eyes were a bit blurred. She had bilateral papilledema and a brain tumour. So there are lessons to be learnt here, and it's very important. So one of the questions that I'd like to ask colleagues is for some advice. At what point should a general practitioner consider, rather than managing this condition, but asking, for instance, for a neurological opinion if they're unsure? And this is the unknown, and I would hope that Dr Goldsmith can probably help me on that.
So I'm Paul Goldsmith. I'm a consultant neurologist, and migraine is really a neurologist's bread and butter activity. We see lots and lots of it, and one of the challenges, I think, is it's just so varied. It can do so many different things, and it makes it fascinating. It can tell us so much about normal brain function, and it also makes it challenging in terms of diagnosis. So a lot of people are easy to diagnose, so neurologists probably don't see those patients. And then there are others that neurologists are reasonably comfortable in diagnosing migraine. But I think we have quite an advantage over GPs in that by the time they see us, there's been the passage of time. There's often been tests done. They may have come via A&E or via general medics and have had a scan. And so we can then more safely conclude it's migraine. And that sort of perhaps makes one of the points that migraine is really a diagnosis of exclusion. So if one looks at the diagnostic criteria, one of the diagnostic criteria is not adequately explained by another condition. So you've always got to have that thought, could it be something else? And the International Headache Society have a set of criteria for definite migraine. Now they have evolved primarily for sort of research purposes to try and define that group of migraine patients where you can be really quite comfortable that it isn't anything else. But there are a lot of patients that don't fall within that sort of tight set of criteria who have probable migraine, but you have to think a bit harder. So if you do fall within that group, then you can be much more comfortable. And so we'll see patients referred up, and they do have those sort of classic criteria. One of them is the thing you've already mentioned, Alan, is that this is a recurrent problem. So if somebody has had 8 headaches over 8 years, one a year, each one's been a little bit strange, but it's lasted 24 hours and then they've been fine for 11 months, and another one you can be sort of quite comfortable that that's migraine. Whereas another headache, which for other aspects may be quite typical of migraine, but it's happening every day. There's no interval of normality, and it's getting worse. This sort of crescendo, that's when you're going to be concerned, could this be the brain tumour? And then you can have a low threshold for referring or doing a scan. And you would see something. It's very rare actually for a brain tumour to present just with headache. Major cause for concern and a driver for continuing headaches of patients. And so we often do the reassurogram for patients and sometimes for the neurologist as well. But in the absence of some abnormality on examination, it's very rare for a tumour just to cause headache.
Well, that's helpful, thank you, because that actually almost goes to the point I was making about the case I mentioned that was getting worse, and why I say, is this the same type of headache you get, or is it different? Can I ask you one question then? As far as migraine is concerned, it's predominantly managed for the most part in primary care, but do you feel the diagnosis is appropriately made by a GP, or do you think they should be referred for the first opinion?
I think it's so common, and looking at the number of neurologists we have, that just for practical purposes, this is a primary care diagnosis, unless it's unusual.
I mean, I have to agree. I think that that's a reasonable diagnosis for a GP to make, provided they are aware of what I mentioned, of the jeopardy of not actually taking care when you should do for things that are changing.
Yes.
And also making the initial examination. And obviously, when somebody presents to begin with a headache, you're going to do a targeted neurological examination, which I hope you'll agree a general practitioner is able to do.
Oh, absolutely. And so there's a migraine phenotype. So migraineurs tend to be quite meticulous people. So make fantastic doctors. So it's overrepresented in doctors, particularly in neurologists. And they tend to be sort of slightly more prone to anxiety. And that sort of fits with, in a migraine, some of the brain circuits being sort of cranked up. So there's an increased sensory flow, there's hypervigilance which occurs.
Yes, I agree. So turning to the other issue that I have, and this is another big issue for general practitioners, there are many different types of aura, but one of the auras that is very common, and I will confess to being a migraineur myself, so I get the visual aura, so I know what it's like, so I can explain it to patients, which is helpful. But the idea of getting the symptoms, but they vary, and some patients will say they've got black spots, some say blurred vision. There must be some, if I like, red flag signs in the visual symptoms where perhaps Mr. Riordan-Eva, the general practitioner, should consider not pressing the panic button, but at least considering that they want a second opinion from an ophthalmologist.
Well, thank you very much, Alan. I'm Paul Riordan-Eva, and until 2 years ago, I was a consultant neuro-ophthalmologist. You're absolutely right about migrainous visual disturbance. The textbooks will tell us about the typical regular triangular zigzag pattern with the coloured lights, the so-called fortification spectra, starting in the middle of the field of vision and expanding over about 15 to 20 minutes into the periphery, sometimes associated with a complete loss of vision with a homonymous hemianopia. But if you ask people who clearly have migraine, actually only a small proportion of those patients will tell you that's what their visual aura is like. And many migraineurs with visual aura will talk about wavy lines, black spots, all things. But the thing that's important to say is, just as you've said before, actually, is that each time they have their migraine, their visual aura will be the same. It's a stereotypical pattern that they get, and they get used to this. I'd certainly very much highlight your comments about escalation of migraine. When I was in clinical practice, a large number of patients in my clinic had idiopathic intracranial hypertension. And if you looked at those as a group, many of them presenting with headache actually had an escalation of an underlying headache type, including migraine. So many of them, in fact, did present with an escalation in their migraine. And the point is that each individual has a certain type of headache pattern that they experience. And if there is something happening inside the head, in the brain, it may actually present with an escalation of that type. And they would have a typical migraine, but it would be more common, more frequent, and it would be a change. That's important. I think from the point of view of the medico-legal standpoint is to highlight, and we see this quite often as a pitfall, is that particularly in patients with a new presentation of headache, it tends to be assumed that if there is a visual disturbance in association with that, then that means this is migraine. And there are many cases we see where patients are being repeatedly presenting to primary care or into accident emergency departments with headache that may be escalating with visual disturbance, and it's constantly said that this is migraine. And the important message really is that not every headache with visual disturbance is migraine. And indeed, as I'll come back to in a moment, there are two particular situations we need to worry about. The first one is raised intracranial pressure, and the second one is giant cell arteritis. And just to talk about those, if you have raised intracranial pressure, you can experience, because of the swelling of the optic discs, the phenomenon of transient visual obscurations, where vision just momentarily disappears, often when people stand up quickly or they strain. Okay, and it can happen quite frequently. A similar sort of phenomenon can also occur in giant cell arteritis, when there is some sort of critical ischemia, and again, it's often when people are standing up, they lose their vision. And these transient episodes are often very important, first of all in the diagnosis of intracranial hypertension, it's important. But of course, in giant arteritis, if you've got these transient episodes, there's a very high risk of progression fairly quickly to permanent loss of vision. And one of the difficulties is, because they're transient, they tend not to be sort of dwelt on. They tend to be sort of passed over. And it's something that's very important to bear in mind. Just to pick up on one of your earlier points, fundoscopy is a difficult skill. Looking at fundi through undilated pupils with direct ophthalmoscope is not always terribly easy. And that means that the detection of papilledema can be quite difficult. Because you've always got to remember that if there is raised intracranial pressure, you don't necessarily get disc swelling. So you've got to be careful, and you've got to rely upon the history. But certainly, ophthalmologists particularly, but also optometrists, have ways of making visualization of discs that much easier. And certainly, if there is a concern, then often actually a referral even to an optometrist. And we see a lot of patients presenting in hospitals who've been seen by the optometrist who picked up the disc swelling. I think, general practitioners, if they can't see the optic discs, they should document can't see the optic discs. In fact, there are often clues in the history that tell them actually something serious, but I think they can also rely upon optometrists to give them some assistance.
So I would perhaps have a question to both of you, really. In that case, at the initial phase of diagnosis, when you see a patient of whatever age, and I might just add that I always feel it's unsafe in an over 50s to consider migraine for the first time. I think that's considered rather hazardous. But in the initial phase, should a general practitioner make sure to their own satisfaction that somebody has had an appropriately satisfactory view of the fundi?
Yeah, interesting. I think the first thing to say is you're absolutely right about new onset migraine, and I would also say that new onset headache with what we regard as typical migraine visual disturbance may not be migraine. It may be a structural lesion, and one of the important clues there is whether that actually is complete recovery. And if the patient is aware that they've had an episode and their vision has not completely recovered to normal, then actually you've got to be concerned there may be something else besides migraine. Okay. I think certainly you've got to, you can't make hard or fast rules, but certainly I think if you have anything that makes you suspicious that there's an intracranial problem, particularly the possibility of raised intracranial pressure, at some stage someone has got to have looked at the optic discs. And you've really got two options, haven't you? Either you are sufficiently concerned about the patient that they need to be referred directly to the A&E department because you are concerned and you can't tell, or secondly, it may be a less urgent situation when then you can actually ask an optometrist to have a look for you.
Yeah, I would agree with the points about the transient symptoms being more concerning. So if the visual disturbance goes on for more than 5 minutes and there's a gradual evolution over 5 minutes, that's actually quite reassuring. If something's lasting seconds, that's a much greater concern. So and the other distinction would be between a positive visual phenomenon and a negative one. So usually in migraine it is positive, so you're seeing extra things, flashy lights, jagged lines, sparkles. You can see negative, you can lose vision, but that makes you think much harder because that's more typical of an ischemic event.
I mean, my own policy is I do advise all my patients at the beginning to go and see an optometrist. I feel that's a sort of a safety net that I'm going to use. But coming back to perhaps even summing up, the issues with migraine are that it is such a common problem. And I know from my experience that I have several patients that will, week in, week out, be calling because they are flattened by it, they're vomiting. It is a horrible illness for some people. It's really difficult. And it does create quite a lot of anxieties for GPs. And I think that what has to be done is what I said at the beginning. You've got to keep taking a history. You've got to ask if there's any change. You've got to look. And I think you can easily get into a sense of shouldn't do, and hopefully I don't do it, a sense of thinking, oh, it's that person with the migraine again, and I know what they just need a strong painkiller. And that's when I think you can fall foul, and that's when the medico-legal issues come in. So if you can say that you have, to your own satisfaction, taken an appropriate history, examined when it's necessary, treated as your feels appropriate, then I would consider that the GP is doing the right things. But it's this issue of alertness, making sure that you do all the things that I've suggested.
Yeah, I'd certainly support that. And in fact, the cases I see medico-legally often with a delayed diagnosis of raised cranial pressure. In fact, the history was there. It's a person who's repeatedly presenting with escalating headache that's becoming more frequent, actually, and they're becoming more severe. And it's just the possibility of migraine is constantly brought up, and the diagnosis is constantly made, and nobody's really taken the opportunity to go back again to the history and say, what is going on here?
Yeah, I mean, the periodicity is one of the most useful things in headache diagnosis. So how often, how long does it last for? And you're looking for that normal intervening period for that reassurance. Now, you can have obviously chronic migraine where it is there all of the time, but you're probably going to be scanning those because that's a diagnosis, again, of exclusion.
I mean, we've concentrated on the doctor's side of this, but my experience of patients who suffer is they will often come along and they're concerned that there's something else seriously wrong. In fact, virtually everybody at some stage comes and says, do you think I've got a brain tumour, or I need, something's wrong with my eyes, and so on. And this is, I think, where, well, I think actually if somebody does have those genuine concerns, you are then obliged to get a second opinion. It's common sense.
Yeah.
Yeah, to scan. I mean, and if you've got a sensation that your skull is being blown apart by a balloon pumping up, or your eyeball on a string being pulled back, the words that patients use, it makes sort of sense to them. There must be something inside. So I think scanning can be therapeutic. Sure.
And the one question I've never had answered to myself either, at what age do you feel that it's appropriate to say somebody's got migraine? At what young age? Because there are very young children. It's a difficult question.
Well, I remember one of my early migraines and being told it couldn't be migraine because I was too young. So it can develop at a very young age. But under the age of 10, it's more likely to be bilateral, frontotemporal. Say if it's occipital, you'd be more concerned. If it's just one side, be more concerned. But it can happen at any age, and it can present de novo in your 70s or 80s as well. But you think harder about other things.
Sure. Well, that's useful information. I wasn't aware of the idea of the bitemporal, but that's helpful, because there are very young children that you feel have got migraine, and as a GP, I think a lot of GPs just hold back a little bit and go and see a paediatrician because they have a concern that you are then basically saying, that's what you are. You are a migraineur, or you have migraine, and it's probably going to go on all your life.
But certainly, I think, then there needs to be complete recovery between the episodes. Certainly, if they have a visual problem and they have a persisting problem, either subjectively or you find there's a field defect, for instance, then you've got to be, that's very highly likely to be a structural lesion.
Yeah, you would expect complete recovery. The other things that you look for, we talked about the say visual disturbance as a visual aura, but you're looking at the other features as well. So you might have an unusual aura, but that patient says that the prior 2 days they were craving chocolate and had fatigue and had hypersomnolence, which is a really useful clue. So if you just take the aura on its own, there may be greater diagnostic uncertainty. But when you look at the other bits of the history, or an unusual visual aura, which is then followed by a sensory aura, which is then followed by speech production problems, so involving different vascular territories, and that's very reassuring.
Well, I think that has been a very useful podcast. I hope I've learnt a lot, and it's been very helpful to have two eminent specialists on either side, because it is a difficult, problematic subject for GPs. Thank you very much.
Thank you.
Thank you.
We hope you've enjoyed this podcast, and remember, for more guidance and advice, you can visit themdu.com or download our app. Thanks for listening.